Uh, just me, sir.
Huh? Only you?
Yes.
Is it round? No.
Just a topic, sir.
Okay. So you are going to present only.
Yes.
Okay. Okay. Start.
Good morning. Today I'm going to be speaking about the cystic neoplasm of pancreas. Coming to the outline, we'll be speaking about how to evaluate cystic neoplasms, the different types of cystic neoplasms, basic outline, management, and post surveillance criteria. So, cystic neoplasms can be classified as neoplastic, non-neoplastic. Neoplastic are further subclassified into IPMNs, mucinous cystic neoplasms, serous cystadenomas, papillary neoplasms, and non-neoplastic majorly being pancreatic pseudocysts. So neoplastic cysts can also be categorized as either mucin producing, like IPMNs or mucinous cystic adenomas, and non-mucin producing, like serous adenomas and solid pseudopapillary neoplasms. So mucinous cysts are considered as malignant precursor lesions, which basically have covered with columnar epithelium, versus non-mucinous cysts, which are mostly non-malignant, which are lined by a simple cuboidal epithelium. So these are heterogeneous group of lesions making approximately 10 to 15% of the cystic lesions of pancreas, with a risk of invasive carcinoma, mainly in IPMNs and MCNs, and SPTs and SCAs have a fairly low incidence of invasive carcinoma. Coming to evaluation, first, majorly we do a cross-section imaging, and the imaging investigation of choice is mainly an MRI to diagnose pancreatic cysts, MRI with MRCP gadolinium-based intravenous contrast agents. CCT can also be done to show the vascular architecture in case of presence of metastasis and any other abdominopelvic involvement. It is mainly done to locate the cyst within the pancreas, to know the size, morphology or shape, and presence of nodules, septa, and its relation to the MPD. So we also have to evaluate the MPD, the size and the morphology, along with the assessment of the surrounding pancreatic parenchymal tissues. So US is also done nowadays, which provides a high resolution imaging of cyst size, septations, calcifications, and nodules with the MPD diameter measurement. It is a second line of examination in addition to CT or MRI. There have been recent advances in US as well, like contrast enhanced harmonic EUS, confocal laser endomicroscopy, and EUS guided elastography. So when do we do EUS? So there are five major associations: American College of Gastroenterology, European Guidelines, International Association of Pancreatology, American Society of Gastrointestinal Endoscopy, and American Gastrointestinal Association. So the major indications are mainly when the cyst diameter is more than 3 centimeters, and according to the IAP, whenever there is a abrupt change in the pancreatic MPD diameter with distal pancreatic atrophy, and the presence of enhancing nodules less than any 5 mm, and when the rate of growth is more than 3 or 3 mm per year according to the ACG, or when the patient presents with elevated CA19-9 and or symptoms of jaundice or acute pancreatitis, this is when you do a EUS. Can also do a cyst fluid analysis, which provides fairly valuable information regarding the helps in differentiating mucinous and non-mucinous cysts. However, they have a low diagnostic yield. We have a CA threshold of about 192 to differentiate mucinous from non-mucinous cysts, with a sensitivity of 75, specificity of 85, and accuracy of 79%. CA99 is a major biomarker for mainly pancreatic adenocarcinomas. In IPMN, elevated CA19 level more than 37 is found to have found in patients with high-grade dysplasia or invasive cancer. Mutations in genes such as KRAS and GNAS are strongly associated with MCNs, including IPMN. Specific proteomic signatures such as panel including MMP9, CA72.4, FASL, IL4 have shown promise in identifying high-risk IPMNs. So this is a table shows the markers. KRAS and genus are mainly elevated in IPMNs, and yeah. Coming to serous cystadenomas, half of the patients are usually found incidentally, and if symptoms are present, they usually present with abdominal pain, palpable mass, and weight loss. So SCS can be microcystic, macrocystic, mixed, or solid. So the microcystic serous cystadenomas have a classical honeycomb appearance with a central calcified scar without hemorrhage. So the septa may centrally coalesce to form a characteristic stellate scar without a calcification, which are pathognomic of SCAs. They are considered benign lesions with a malignancy rate of less than 1%, with risk factors of female gender, old age of patients when first detected, and large cyst size being major risk factors for conversion to adenocarcinoma. So, as these are majorly asymptomatic and fairly benign, they can be confidently followed up. Short-term follow-up up to 1 year is initially recommended. If and usually the median rate of growth is also slow, around 1.8 mm. And if the patient remains asymptomatic, further surveillance can be discontinued. However, if we have diagnostic uncertainty or there are atypical features like solid components or if it's macrocystic, then further assessment with EUS or cyst fluid analysis has to be done. In such cases, branch duct IPM protocols have to be followed, which I'll be speaking about later. So surgical resection is mainly for two indications: when there is diagnostic uncertainty, which is much more common than, and when the patient is symptomatic. So misdiagnosis is fairly frequent. Around 18 to 25% patients are misdiagnosed as serous cystadenomas. So thorough preoperative evaluation, including EUS, is necessary. So whenever surgery is indicated, we usually perform a parenchyma sparing, minimally invasive procedure wherever it is feasible. Open approach is done whenever there are large tumors to retrieve the specimen, or lesions involving the pancreatic head, or when the lesion is too close to the portomesenteric vessels. And then we do the open approach. So usually no postoperative surveillance is required after section if the histopathology confirms a serous cystadenoma. Mucinous cystic neoplasm is usually like communication with the MPT and contain mucin-producing columnar cells with classical ovarian stroma surrounding the columnar epithelium. Usually found in the body and tail, around 40 to 50-year-old females, and these are usually discovered incidentally, but patients may have symptoms. So any macrocystic lesion in the distal pancreas of a female patient should be considered highly suspicious for an MCN. They're usually unilocular, but they may contain cysts as well. So when the lesions are multilocular, they're typically macrocystic versus serous cystadenomas, which are microcystic. Lesions can have peripheral axial calcifications, which are diagnosed on non-contrast CTs. Every evidence of mural nodularity is considered concerning for invasion. The invasive rates of invasion range from 10 to 50%. Risk of malignancy include the male gender, pancreatic head and neck location, large lesions more than usually 4 centimeters, mural nodules, and when there is duct dilatation associated with the lesion. So historically, surgical resection was considered mandatory for all MCNs. So early surgical series rates, the malignancy rates were up to 36%, as it was believed that the untreated MCNs would inevitably progress to mucinous adenocarcinomas since given the young age and long life expectancy. So prior to the WHO classification, MCNs were grouped under, they were often misclassified and grouped with the IPMNs. And after that, they have been separated. So our recent evidence shows that the rate of malignancy is comparatively less, around 12 to 17.5%. So we can shift to a more selective strategy. The recent versions of the IAP and the AGA guidelines do not address MCNs. They focus exclusively on IPMN. The European guidelines, the 2018 European guidelines are the latest with regards to the MCN and how to manage them, which recommend surgery only in the presence of high-risk features like cyst diameter, cyst size more than 4 centimeters, presence of mural nodules or enhancing walls, and if the patient is symptomatic and the lesion is symptomatic. So these are one of the two studies which shows MCN. One was a meta-analysis published in HPB in 2023 by Pollini et al. So which showed that the pooled malignancy rates was around 16%, and malignant MCNs were larger than benign ones, with a size threshold being around 65 mm in the first study, and the presence of mural nodules were also associated with the diagnosis of malignant MCNs. The second study by Machigiani was published in British Journal of Surgery in 2021, which also showed similar rates of malignancy rates of around 10.9%, which suggested the predictors of malignancy were mural nodules, size of at least 5 centimeters in the study, and the CA19-9 elevated CA19-9 levels. So risk assessment and surgical indications. Whenever you detect high risk surgery, high risk features on CT, EUS is recommended to confirm the mucinous nature of lesions and to assess the mural nodules. If malignancy is confirmed, standard oncological resection with, since they are mainly in the body and the tail, typical distal pancreatectomy with splenectomy is indicated. However, if the lesion is small and considered low risk, then a spleen preserving or a parenchyma sparing resection can be done. MCNs are usually encapsulated and expansive and not infiltrative. So they are candidates for minimally invasive surgery. So it is also important to avoid intraoperative rupture of MCN as spillage can cause peritoneal dissemination. Pathological studies show a 23% misdiagnosis rate for MCNs as well. So initially lesions which are suspected to be malignant can turn out to be benign. So there's a need for better diagnostic markers present. Surveillance in the absence of high-risk imaging features and after mural nodules have been ruled out with endoscopic ultrasound, surveillance is a reasonable option. The European guidelines published in 2018 recommend a follow-up with CA19-9 EUS and/or MRI every 6 months for the first year and annually thereafter. Cyst growth is a key factor when determining we have to undergo a surgery or not. But decision making should also incorporate patient preferences, anxiety, plans of pregnancy, as they usually size usually increases during pregnancy, and family history of pancreatic cancer. So this is a good slide regarding how when to go for surgery. Whenever there are high risk features with mural nodules, size more than 4 mm, symptomatic and increased CA19 levels, and there is a clear diagnosis of MCN, you go for surgery. If you're still confused, then you can confirm with EUS and then go for surgery. Patient factors like age, comorbidities should also be taken into consideration when planning for surgery. Now coming to IPMNs. IPMs are epithelial tumors which arise from the MPD or the branch ducts, causing duct dilation from mucin production. In contrast to MCNs, IPMN occur equally both in men and women with a peak incidence between 50 to 70 years. The main duct IPMN is characterized by diffuse segmental dilatation of the MPD without other reasons for obstruction. And they have cysts which have communication with the main pancreatic duct without significant dilatation of the MPD are defined as branch duct IPMNs. So IPMN is classified as mixed IPMN when there is branch duct dilatation associated with the main dilatation. Around 60% of the main duct IPMNs are malignant, with high-grade dysplasia and invasive cancers. 45% have invasive adenocarcinoma. So it is recommended that patients with main duct IPMN should undergo resection. Invasive carcinoma or high-grade dysplasia is reported about 12 to 30% who undergo resection for branch duct IPMN. Mixed duct IPMN have rates of carcinoma in between those of branch duct and main duct IPMN. Based on cellular morphology, they can also be classified into gastric, intestinal, pancreatobiliary, and oncocytic. And based on the Baltimore consensus, into low-grade, high-grade, or invasive carcinoma. So IPMN associated cancer malignancies, around 20 to 50% of the resected specimens have found to have invasive carcinoma. The main issue is with IPMN is there is increased risk of development of adenocarcinoma elsewhere in the pancreas even after resection, around 1 to 8%. The outcome, the survival outcome of patients with IPMN is 60% 5-year survival rate, which is better compared to the pancreatic ductal adenocarcinoma rate. IPMN associated cancers have lower rates of T-stage lymphodmetastasis when compared to ductal adenocarcinoma. So patients with colloid subtype of IPMN have significantly better survival than both conventional and patients with invasive tubular IPMN. So the tubular variant and lymph node involvement are considered negative factors for survival. So according to the International Association of Pancreatology, there have been many guidelines. 2006, there was a Sendai guidelines. And then 2012, you had the Fukuoka guidelines, which included the worrisome features and the high-risk stigmata features, which corresponds to the European guidelines, relative indication and absolute indications. 2016, you had the revised Fukuoka guidelines, which incorporated additional features into like obstructive jaundice, lesions of the head of the pancreas, mural nodules more than 5 mm, MPD size more than 10 mm into high-risk stigmata. 2024, there was the Kyoto guidelines, which provided the framework for when to undergo surgery in patients with IPMN. So high-risk stigmata, whenever there is more than or equal to one high-risk stigmata, it's an indication for surgery. MPD diameter more than 10 mm, contrast enhancing nodule more than 5 mm, solid component in the MRI, positive cytology results, obstructive jaundice caused in the head of pancreas. Whenever where there was more than or equal to two worrisome features or more than one in a young fit patient or patients with repeat acute pancreatitis, patients can undergo surgery. So the worrisome features were mainly acute pancreatitis, increased CA99 levels, cyst size more than 3 centimeters, new onset diabetes, nodules less than 5 mm, elastic contrast enhancing walls, MPD dilatation between 5 to 10 mm, abrupt change in the pancreatic duct diameter, and cystic growth rate of more than 2.5 mm per year. So post-resection surveillance is recommended yearly for patients without any additional risk factors and every 6 months for patients with high-grade dysplasia or family history of pancreatic cancer. The coming to the choice of surgical procedure in such cases is mainly based on preoperative imaging features in the presence of high-risk features and intraoperative frozen section findings. When invasive carcinoma is suspected, radical pancreatectomy with lymph node dissection should be performed. That is oncological dissection. Whenever non-invasive lesion is suspected, you can undergo a parenchyma preserving procedure. Where surgery is indicated, the main goal is to treat pancreatic ductal carcinoma at the earliest stage. The current guidelines suggest a standard oncological resections with lymphadenectomy. Adequate nodal harvest is necessary, at least 10 lymph nodes for staging. Ideally, more than 20 nodes in pancreatectomy and more than 25 in total pancreatectomy. The type of surgery again depends on the location of the lesion and can be performed either with open or minimally invasive procedure. PD, pancreatectomy, is indicated when the lesion is in the head and situate on the neck of the pancreas. IPMNs are typically localized to the pancreas, so they rarely require vascular or multivisceral resections. Distal pancreatectomy is indicated for lesions of the body and the tail, although splenectomy remains the standard in oncological resections for benign or low-grade lesions. Spleen-preserving distal pancreatectomy can also be done. Total pancreatectomy is mainly reserved for diffuse MPD involvement, multifocal nodules, extensive cystic disease in patients with familial PDAC. Although total pancreatectomy may improve disease control, it is not associated with prolonged overall survival because of the significant morbidity associated with it, because brittle diabetes, severe exocrine efficiency. So every case has to be judged on a case-to-case basis if a patient has to undergo total pancreatectomy. Diffuse MPD dilatation does not always reflect a diffuse epithelial involvement. So the upstream dilatation may be a result of a focal obstructive lesion in the pancreatic head. So in case of diffuse MPD dilatation, guidelines recommend partial resection with intraoperative frozen section analysis of the margin before considering a total pancreatectomy. Parenchyma sparing procedures like enucleation, central pancreatectomy can also be done, but these are done in highly selective cases when you're absolutely sure that it is non-invasive. Low-grade branch duct IPMNs, less than 3 centimeter size, without any features of suggestive of malignancy. So in intraoperative frozen section, if the margin shows low-grade dysplasia or normal epithelium, further resection is not indicated. If the margin shows presence of invasive carcinoma or high-grade dysplasia or a denuded duct, additional resection is indicated till the negative margin is achieved. IPMN is recognized increasingly as a diffuse disease involving the whole gland with multiple skip lesions. Around 15% of the lesions may recur after section, despite having negative margins at intraoperative frozen section. This diagram shows the management. Branch duct IPMN single or multiple. Whenever there are multiple lesions in the branch duct IPMN, consider the cyst which is at the highest of risk of malignancy and then operate according to it. A mixed duct and main duct. So in main duct IPMN, you consider total pancreatectomy Again, you risk chances of brittle diabetes and total exocrine insufficiency, pancreatic insufficiency in that. And you in partial pancreatectomy, you always do a intraoperative frozen section to know when to stop. Postoperative management. 34 patients of the IPMN patients, invasive carcinoma has already occurred. So the overall recurrence rate after section of the IPMN is about 45% at 5 years and 40% being local, 60% being distant. The survival benefit from chemo is only in patients with nodal involvement and elevated CA19 levels with no clear impact on recurrence rate of patterns. The remaining 66% patients in the biopsy specimen, there is low-grade dysplasia or high-grade dysplasia. After resection, around 20-25% will develop benign changes in the remnant pancreatic lesions, which can be safely observed, whereas 2-3% will develop malignant disease. These are the guidelines again, which I've already discussed previously, European and the IAP guidelines with regards to the IPMN, MCN, serous adenoma, and solid papillary neoplasms. Coming to the imaging surveillance interval for non-resected pancreatic cysts, in IPMN, according to the AGA, cyst size less than 3 centimeters, surveillance interval is about 1 year, and then every 2 years. Imaging modalities is mainly MRI with MRCP in such patients. And according to the IAP, IPMN size, again, they classified based on the size of the lesions when the surveillance interval. As the size of the lesions is smaller, the surveillance interval is much bigger. So it is mainly with regards to the mucinous cystic neoplasms and IPMNs. Coming to solid pseudopapillary neoplasms, these are rare neoplasms, mostly asymptomatic. Diagnosis is made radiologically with these are well demarcated lesions, not communicating with MPD, with mixed or solid morphology in 91% and cystic in 9% of the cases. Earlier, they used to be the malignancy rates were about 60-55%. This is due to misclassification, particularly with cystic neuroendocrine tumors, as they appear similar. Our immunohistochemistry, which helps in differentiation, SPNs are positive for beta-catenin and CD99 and negative for chromogranin, trypsin, and E-cadherin. So 2010 WHO classifications defined SPNs as low-grade tumors with malignancy characterized by angioinvasion, perineural invasion, deep infiltration, and distant metastasis. Using these criteria, more recent series reported malignancy rates of up to 16%. So due to the malignant potential and the good post-resection prognosis rates, the surgical resection is recommended regardless of the size of the lesion. Small encapsulated lesions with low risk features, parenchyma sparing procedures like enucleation, central pancreatectomy, and spleen preserving DP can be done. However, in larger infiltrative lesions, oncological resection is indicated. And there is no standardized follow-up for SPNs due to the but recurrence rate is about 1 to 5% at 5 years, even after azero resection. Typical protocol may include MRI or CT every 6 months for the first 2 years and then annually up to 5 years, and later symptom driven. Some people, experts recommend lifelong surveillance, especially for patients with high risk features like infiltrative growth, pancreatic parenchyma invasion, or capsular involvement. So this is a brief summary of what I've already discussed with regards to the different types of pancreatic cystic neoplasms: branch duct IPMN, main duct, mucinous, serous cystectoma, and solid papillary neoplasms. The malignant potential of each of them, with main duct IPMNs having the highest rates of malignant potential. So, including the incidence of neoplasms is rising due to the aging population and the widespread use of cross-sectional imaging. So, when a pancreatic cyst is incidentally detected, establishing an accurate diagnosis is crucial to avoid unnecessary resections of benign lesion while ensuring a timely intervention in those cases at risk of invasive carcinoma. Differentiation among different types of PCN and appropriate assessment of malignant potential is necessary to guide decision making. So there is an urgent and a need for more reliable, non-invasive biomarkers to reduce the risk of misdiagnosis and overtreatment in patients with pancreatic cystic adenomas. Thank you.
I thought you would also give some data from ILBS at least, that cases any operated and in various, this was just a simple review. I don't know what was the department thought about the round today. So did you see some data or no? No. All right. Any comments from anyone? That's all. There's no other presentation. No? There's no other presentation. Okay. Any comments?
बेटा बिना डेटा के क्यों प्रेजेंट करना है ना? आई डिडंट न्यू यू आर प्रेजेंटिंग दिस एंड इफ यू कम विदाउट डेटा हियर आई डोंट लाइक इट.